Good morning, everyone. I'm Neena, one of the clinical fellows. It's a nice kind of continuation from your Gil's talk because in your slides, most of the family wanted to know how the clinical research, how the clinical trial actually works. And I hope my presentation is going to tell you a little bit about how the kind of protocols, written research protocols, will be translated into real life. And then, so my talk will be divided into the first part, the protocol, and second one into how they are translated in real life. So a little bit about Alexander disease. So they are first described in 1949 by Dr. Alexander. So he's described a baby who is 16-month-old with the developmental regression, a large head, and a seizure, just like the previous kind of slides that we talked about. And it is an inherited white matter disease affecting the white matter of the brain. And tomorrow there will be a dedicated session on Alexander disease by Dr. Green. So I will not go so much into the detail of this disease. So to tackle this disease, Ionis has devised a drug called zilganersen. It uses a technology called antisense oligonucleotide therapy, ASO therapy. So I'm trying to kind of explain it in more layman's term language. Let's say my aim is to bake a cake, and this recipe is in the library, and then that recipe, we will call it DNA. And then for me to make the cake, I need to make a photocopy of the recipe. So that will make into a photocopy, i.e. RNA. And then I bring the recipe back home, and then I follow the recipe to make the cake, and then the cake will be the protein. So DNA, RNA, and cake. In Alexander disease, there is an issue with the recipe written in the library. So even if I photocopy the DNA, the recipe book, original one from the library, there will be faulty instruction leading to faulty cake. So the aim of this ASO therapy is to kind of prevent, yes, we can't change the library book because that belongs to the library. However, if we can kind of reduce try to kind of correct or not even produce the wrong photocopy of that recipe, then we will not be able to make wrong cake. So that's kind of an idea behind it. And Ionis has got this new medication called Ionis 373. Its commercial trade name is zilganersen. And then there will be another dedicated session by Rob tomorrow about zilganersen. So you will get to hear more about that tomorrow. So this is the protocol part, very dry, hard ones. So this is phase 1 to 3, multi-centered, meaning that there has been many other different cell centers around the world. Double-blind, meaning that I don't know, the doctors or researchers do not know which medication we are giving into the patients. Placebo-controlled, it means it has got some of the patient will receive placebo, some of them will receive actual medication. And then that was by the time that I joined the study, it was in phase 3, meaning that they are at the end of the clinical study. It involved 3 monthly intrathecal injection of this medication, so meaning that we will be injecting this medication into the spine every 3 monthly. And then the first part of the clinical trial, they will be all blinded. So first year, nobody knows which medication they are receiving. Is it placebo medication? We don't know. The second part we move on, it will be open label, meaning all the patient who is recruited to the clinical trial, they will be receiving the actual medication. And after that, there will be a long-term extension period, about 5 to 6 years. We will be closely following the patient while they're having the medication in the meantime. Since the 2022, there has been 2 UK centres. So there were National Hospital for Neurology and Neurosurgery, i.e. Queen's Square for the adult team. And then obviously there is a children's team at Great Ormond Street, and I have been involved in both clinical trials as sub-PI. How do we know whether this medication actually works or not? So the primary endpoint, how we measure whether this medication is working or not, is to see how much was speed, how fast can they walk a 10 meter. It's by the actual motor component of how the patient is walking. And obviously that's not going to be enough. So we look at the patient in more of a multifaceted way. you're looking at the patient-reported outcome. So we ask a lot of questions to patient, like how has it been doing in terms of the breathing, feeding, neurological issues, seizures. We ask a lot of questions every time you come and see me. And then we have psychological review. We have take a picture of the children walking. We do the physical and neurological examination each time they come to a hospital. We'll be collecting blood, urine, and CSF samples. And obviously, there will be serial MRIs to see whether there is any kind of changes over the time. So this is the kind of a recruitment criteria, which I don't want to go into so much at the moment, which I will talk about more about it. But I just wanted to show you how strict there are so many criteria we need to think about in terms of written paper. So that's the protocol part I talked about, very hard and dry. Now I'm going to move on to my personal experience and how these protocols were translated into real life. So this is going back 3 years ago, August 2022. I was having a lovely kind of a family trip to Scotland. And then at the time, because we are setting up the clinical trial, so I was listening, this is the actual screenshot of what we talked about. You can see on the top, 31st of August 2022. So this meeting was like hosted between different countries. They were in the US time, so I think it was at lunchtime. So there lots of paperwork and meetings, so I was attending at the time. And luckily, I was not involved in the legal and budgeting part, but I'm sure there has been a lot of blood and tears that went into this legal and budgeting part. And then there are a lot of paperwork and fine details when it comes to implementation of these protocols onto the NHS hospital. Obviously, staff has to be trained. And then there is the next part where we have to find, yes, there could be this setup, but we also need to find the actual patient who can be recruited to the clinical trial. So these are the trainings I had to do, like CGP trainings and how to do the intrathecal injections. And a lot of meetings, as you can see there, the minutes that I took, and so many files and PDFs that we had to go through. And there were lots of interaction with the pharmacy because this is a control medication, so there have to be kind of lots of discussion with the pharmacy and how we are going to implement that. And because this is a trial, we involve a lot of other MDTs, i.e. psychologists and physiotherapists. So we had to do separate meetings with them to kind of see how they are getting on and how they can actually implement these protocols in their practice. So after that, September, October time, 2022, so where to find the patient? And then would they meet the recruitment criteria? And then is it even logistically possible for the patient to come to see us? And then will they agree with all the little fine details of the consent form? So there are all kind of challenges that we were kind of posed with the challenges at the time. First of all, where to find them, where to find the potential candidates. We looked through the patient record in our system, and obviously we sent out the emails to the professional groups all over the country. Is there any possible ones that you can recommend? And of course, we reached out to Alex TLC and other groups to find out if there is anyone who they can recommend. And now there's an up and running inherited white matter disease disorder patient registry, which is going to be more helpful in the future. And as the trial went along, we also received a lot of referrals from the local pediatrician and neurologist as well. So there are 5 kind of resources that we were trying to recruit the patient from. Would they meet the recruitment criteria? So yes, we will go through it one by one. So there is something called inclusion criteria. First of all, you need to have the diagnosis, the correct one, which is consistent with how they are clinically, whether they have the genetic confirmations and also brain imaging consistent with the disease. So even if you have the clinical disease, if it is not included in that, then we will sadly not meet the inclusion criteria. And then this is another point that I didn't know beforehand, they need to be kind of stable in their medications. They need to be well enough to be able to participate in the clinical trial. There was one patient who incidentally was found to have a hypertension before the screening. So we couldn't recruit the patient, although hypertension was something that we think, as a medical people, something treatable. But then, because within 3 months of the screening, the patient had a newly diagnosed hypertension, because of that, the patient was not able to participate in the clinical trial. Also, there's a thing about the reproductivity, and then there's an age gap between 2 years and 65 years. Next one is the exclusion criteria. So if they are very unwell, obviously they will not be able to come into the clinical trial. And because this is the intrathecal spinal injection, there could be a risk of bleeding into the spine. Therefore, they should not have any kind of bleeding issues. And also there is an important one, unable to comply with the procedures, i.e. if the child or somebody who is not able to kind of do blood tests quite regularly because of they are combative or whatever reason, then they are excluded. And if they were treated or recruited for other therapies or trials, then they will be also excluded too. And then, because we were at the end of the clinical trial, there were the specific stratum, the group of the patient the ionists were looking for. So this is the slide that I was showing you earlier on. So they were only looking at this very specific group of the patient at the screening, just because we're at the end, they were looking for a certain group of patients to build up the number of the cases so that it will make more statistically valid result. So they should be aged 5 and old, so not too young. And then if they're old, then they should have the symptoms and signs within 5 years of the screening, so not too advanced disease, as it were. And this is the most important part. They should be able to walk, i.e. we should be able to measure the speed that they are walking, but at the same time, they shouldn't be totally normal walking, i.e. they should have some sort of a degree of impairment. So for example, we had one patient who fit this criteria, but then didn't require any kind of walking aid or had the normal walking. He was able to walk, run, everything. Because he was too well, we were not able to recruit him. So when it comes to clinical trial, there are specific criteria that you should be looking at and then see, although we need to see whether they can actually fit into the specific group of patients we are recruiting. That's something that we need to be bearing in mind as parents. So the second challenge was whether this is logistically possible. So this was a very labor-intensive clinical trial. It involved at least 8 visits per year in person. But there are also 4 of them, they require 3 monthly, 2-night stay. And also there are monthly phone calls. So as you can imagine, if you live a very busy life with other kids, it can be quite difficult. And if you live quite far away from London, and it can be also quite physically difficult too. And then because this is the intrathecal injection, and when it comes to children, they rarely kind of can tolerate the intrathecal injection awake. So that means they need 3 monthly general anesthesia. And then general anesthesia usually means they need to be fasted beforehand. And the next one is the whole day is very packed with so many activities. And this is on the top of the other clinics that you might have. For example, the children with the Alexander disease, they might have extra kind of clinics on the top of the clinical trial, i.e. they might be going to see respiratory physician, they might have to see physiotherapists, speech and language therapists, dietitians. So this is all on the top of the normal NHS clinical work that you have to take care for your children. Luckily, the transport has been always booked for them, so this is another thing that. And there was one patient who has been living 3 hours from the hospitals, and then that patient, because of this regular commute that they have to do, they also had to drop out in the middle of the clinical trial because that just became simply not possible for them to carry on. Would they agree? So before the consent, we usually give the participant information sheet called PIS, and this is like a 20 pages document entailing what it involves, what is it required, and all this fine print of the conditions. And obviously you need to read it very carefully when you're offered one, and you can ask questions anytime. And if you have teenagers, then there is a separate assent, which is more in plain language for them to kind of understand better. You always need to remember that you can always withdraw. And then every visit you come and see us, we check the consent all the time as well. So it's not like once you sign, there's no way back. And sometimes as the trial goes along, there could be some changes in the protocols. So sometimes we do re-consenting too. This is just to demonstrate what happens in a normal visit day. So my lovely research nurse, Rachel, has devised this lovely flow sheet. So this is all the things that has to happen on the day, such as weight, vital signs, ECGs, physiotherapy, bloods, doctor's review, exams, psychology, checking the consent, pre-op checklist, questionnaires, psychology, and all these examinations. So this, as I said earlier, is quite a busy day. And later on the clinical trial, we had to add extra ophthalmology clinic, which was another extra kind of complication because we had to set a different day and liaise with the ophthalmology colleagues to kind of do this review. And because as I mentioned, for intrathecal injections, you need to see, it will be done on the GA, so you have to see the anesthetist beforehand. Sometimes, 1 yearly, you will have MRI, so that's another kind of level of organizations that you need to do on the top of the IT, intrathecal injections. As I mentioned, they're intrathecal dosing. And after that, there will be serial observations, bloods, and clinical examinations. And we also ask a tablet where it contains the questionnaires to the parents, they can answer the questions too. So this is the picture for our first visit and the dosing. And this is my research nurses and Nahed, who is just sitting at the back there. The difficulties from parents' point of view, which I'm sure Nahed and then Gil will be able to answer more in questions, but then the visit can be long and tiring. There could be frequent interaction with the research team. Some people find it very overwhelming. There could be frequent blood taking. Obviously, there will be missing schools and missing work, and there could be potential side effect too. But then the perks from the patient point of view is that we do close monitoring. And you can discuss with concerns with medical team and nursing team anytime. All my patient knows my number, and they have been contacting with me like all the time with no problem. And then I can facilitate referrals and support letters. There you will get to meet the MDT, physiotherapists, SALT dietitians, and obviously you can be offered a life-saving medication in the future too. So upcoming futures. So you will get to hear from Rob tomorrow what is the outcome of a preliminary outcome from the Zilganersen trial soon, tomorrow. It will be available from this year, towards the end. So all in all, the last 3 years, as a clinician, as a very junior clinician coming into the world, this has been a great learning experience for me. So I hope that I have shown you how the protocols on the paper was translated into the real clinical trial. And I have given you some life examples, and I have described some challenges to consider as a parent. And over the time, I have gained great friendship. Where's the other one? So I'd like to give special thanks to my research team at Great Ormond Street and Queen Square, and obviously the IONIS team who has been holding my hand all the time. And of course, my parents, my patients, my parents throughout this journey. It has been a very good learning opportunity. And I'm looking forward to see the result of the clinical trial soon. Thank you.
Okay, I'm going to put up the Slido questions quickly, and if you have any questions, Neena can answer them while you respond. So if you have a question, just raise your hand and we'll bring a microphone to you.
How many patients are recruited?
So we screened about 6 of. We recruited about 6 patients, and then there were 2 screening failures, and 3 children in the end, and 1 adult patient. And 1 adult patient, as I said, they were not able to continue with the work commitment. However, we still have 3 patients at Great Ormond Street that is going on.
Any other questions?
This is a worldwide kind of a clinical trial, so there are multiple centers throughout the world. So all the results will be amalgamated into one. So I think 3 already for us has been quite a good amount of recruitment. They give us plenty of work for us to do.
Any other questions?
No? So if you have any questions in the end, just feel free to approach me anytime. And also Nahed and Gil will be here so that we can also help you with any questions in the end. Thank you.
Thank you. Thank you so much.